Tell me.
Like yesterday we were supposed to come for one PTSD test for the staff, but he had like
Fever.
fever.
Yeah.
So we didn't come. Last night the fever was like 101. 1.4. Okay, so and that was when like I
Yes,
gave
yes.
one dolo for him. Then in the morning, Shreya gave one tablet. Mom had been given. So in the evening, I gave him one dolo, and then he sweat out once and he slept. In the morning again, it was like 99, 98 point something. And so I didn't. Mom told me if it is there, don't get it. I was like, okay, so morning what is happening? The fever has reduced. Now when I checked, it was 97 point something, 4 or 8. But the problem is, now he has too much cold and his nose is blocked. So I was like, should I give Dolo or should I give which tablet along with these tablets? Because these are the tablets which doctor has asked to give. I'm giving him these tablets. So
Only one PTSD was
pending.
pending.
Today was pending. So mom told
Any other problem? Fever,
he's feeling
fever, other
drowsy.
that's all. Cough or burning.
No, I couldn't have I just asked him.
Must ask him. Other than fever.
And now he just has cold and nose is blocked. He's having difficulty breathing.
He should get overcome.
So it's tested.
What's your
So write up another thing.
nebulization? What's your nebulization?
I've given him steam also.
Yeah. But along with that, nebulization with dually.
So those drop.
No. Yeah. That's wrong.
Like is that the instrument or just drops?
No.
Like he just needs to
Tablet.
I've given him Dolo today morning one and last night.
No, you should give. If there is fever,
If there is no fever,
then
only for cold. Hello. Papa. Hello. Papa, I can hear you. Yes, with me headache.
How many children you have? How many children you have?
I am just married, sir. I mean, just married in the sense 1.5 years.
Okay. My elder daughter in MBBS.
Where, sir?
Ramaya, Medical College.
Okay.
Younger one is first PSC.
Okay.
Very cold breathing ಸ್ವಲ್ಪ ಪ್ರಾಬ್ಲಮ್ ಅಷ್ಟೇ ತಾನೆ ಮತ್ತೇನು ಇಲ್ಲ ಚಳಿ ಎಲ್ಲ ಕಡಿಮೆ ಆಯ್ತಲ್ಲ ಓಕೆ ಸೊ ಹೆಡೇಕ್ ಇಲ್ಲ ತಾನೆ ಓಕೆ ಬೇರೆ ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ತಾನೆ ಬೇರೆ ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ತಾನೆ ಬಾಡಿ ಸ್ವಲ್ಪ ಓಕೆ ಡಾಕ್ಟರ್ he just has light headache and a little body ache.
Sanjay, his body ache and
Body and light headache, and he just feels like too much cold breathing, a little breathing issue because his nose is blocked. So I gave him steam and fever now, and like only last night and morning it was there. Now it is 97.4.
I have written that even.
This is for cold.
No, for fever and the blocked nose is there. No?
Okay. But now he doesn't have fever. Should I give Dolo or no?
SOS. SOS. If it is needed, then give.
Okay.
Otherwise.
Okay. And this how many days?
For 5 days.
5 days. So next BPSD, when should he come? Like tomorrow at what time?
No, not tomorrow.
Monday.
Monday.
Monday. Tomorrow not required, right? And this how many times is this that like a stick where you need to put in your nose and inhale? That one is nebulizer.
No.
Then
There is a you can bring in here. Here we will give it. It costs 50 rupees.
Okay, so I should just ask for a nebulization.
Yeah.
And so how many times that should be taking?
What tablets 2 times?
No, this is
Nebulization 2 times.
2 times in a day, like morning and this is after food tablets.
Yeah.
Okay. So don't know only when it is required. And doctor, one more thing, like this tablet which you have written, it is for cold and fever.
Yeah, both.
But if he doesn't have fever, it's okay to give.
Yeah.
Body pain, headache.
Yeah.
Yes. Because no, he's scripting that he already has so many tablets, right? So he's not ready to take it. Okay, thank you. So tomorrow doctor will come for Monday. Is it on the time of Sunday or should I call him?
Yes, over to you, Mr. Vidyashankar.
On Sunday they will call.
Yeah. In fact,
Vidyashankar, your voice is muted.
yeah. Good evening. Am I audible to each one of you?
Yes. Okay, yeah, please.
Yeah. Thank you. Thank you so much for the confirmation. In fact, good evening. Good evening to each one of you. My respects to Dr. Srihari as well as Dr. Kushbu. Good evening. On behalf of Alchem Laboratories, myself Vidyashankar, I work in this organization as a training manager. I welcome our moderator, Dr. Srihari sir, and as well as the speaker, Dr. Kushbu, and all doctors who have joined us today for this virtual webinar on the topic called as comorbid depression in women. Alchem has always been at the forefront when it comes to scientific dissemination of knowledge. Comorbid depression and anxiety in new normal is a step further in that direction. Comorbid conditions with depression and anxiety is on a rise, especially in these challenging times. And to cater that, we would like to hear from our experts to give us the direction based on their experience and expertise. To help us navigate through the meeting, we have Dr. Srihari, who is a very eminent personality, who has a rich experience of 25 years and who is the director of the hospital, it is there in the Sanjay Nagar in Bangalore, right? And the name of the hospital is SJ Hospital. And today we have Dr. Srihari sir with us, who would like to take it forward as the moderator. Now invite Dr. Srihari sir to set the context for this meeting and introduce the speaker.
Thank you.
Thank you, sir. Over to you, sir.
Good evening, everyone. My name is Dr. Srihari Reddy, physician from Bangalore. Comorbid depression has become a growing concern in today's world. Today we have with us Dr. Kushbu Divani to discuss about comorbid depression and anxiety in women. Dr. Kushbu Divani had an MD psychiatry from S. Nijrengappa Medical College, Bhagalpur. She holds second rank in the University of Rajiv Gandhi. And she has trained in research methodology workshop on conducting research, Department of Medical Education, SNMC. Trained at Department of Child and Adolescent Psychiatry, NIMHANS. Trained in de-addiction unit of Department of Psychiatry, NIMHANS. She has also been a part of many conferences like IPSKC, PGCMB at SDM College of Medical Science, CME on investigations in psychiatry at SNMC, Bhagalpur, CME by NIMHANS and the Society for Bipolar Disorders India. Participated in various community-based health education and activities held in urban and rural areas in Bhagalpur. Her publications includes clinical and socio-demographic profile of patients with alcoholic dependence syndrome, pathways to psychiatric care, study of psychiatric morbidity among health professionals of different groups using a general health questionnaire. Her work experience includes psychiatric consultant at Psycho Wellness Center, Dwarka.
Sir's line is got disconnected. We'll join back. I think, ma'am, I think there could be some technicality issue. If you join back, I think by the time you can start the presentation.
No problem. Actually, I wanted to thank sir for the introduction and thanks to the ITEM team for giving me this opportunity. Depression in women, we all know, is very common and it's a topic which is very close to my heart. I would like the presentation to start so that I can start today's topic.
Main composition is same, but
And sir is back. Thank you, sir, for the introduction. We lost you there for a moment, but with your permission, I would like to start the presentation,
Yeah,
sir.
please start.
Yes, thank
bring
you.
the message of the game.
Can we have the presentation?
But now if he doesn't come, is there any other option?
Breathing difficulty.
Like not completely, but his nose is blocked. So after I give him steam, he feels his shoulder.
Then remove.
Nothing else. I can repeat steam like every 2-3 hours.
Yeah,
A plain bottle or should I put nail beads or something?
some consultants or
I think the presentation need to be uploaded.
I can just do that.
It's there.
Yeah. I'm just yes.
So depression is one of the very common disorders. It is so common that in fact the WHO decided that we should have a whole year dedicated to depression. So today we are going to specifically talk about depression in women and comorbid depression in women, that is depression which occurs with other physical disorders or medical disorders in women. So just a brief introduction of what is exactly depression. We all know depression as a disorder which is characterized by sadness, but there are other dimensions of the disorder is in terms of other symptoms like inability to experience pleasure, cognitive symptoms like difficulty in concentrating, difficulty in paying attention, having a negative view about oneself, about others, as well as the future, hopelessness, helplessness, or worthlessness as we call it. There are also physical and behavioral disturbances which are seen in depression, that is fatigue, low energy, inability to get out of the bed, difficulty in falling asleep, loss of appetite, lethargy, agitation, social withdrawal, and somatic complaints. So you would have seen there are a lot of individuals or a lot of women in particular who come with somatic complaints like pains, there are body aches, there are unexplained weakness that we see. So we have to rule out or we have to keep in mind depression as the diagnosis in such females or women. Also, depression can interfere a lot with individuals' ability to function. So, a lot of individuals may not come to you in early disease phase, but they will come when it actually interferes with their day-to-day life. The getting out of the bed is a problem, brushing one's teeth is a problem, they're not able to bath daily, they are not able to go to work. So, these are few things which actually disrupts the whole day-to-day activity of a person who is suffering from depression. It is also seen that 1 in 6 persons experience depression in lifetime, and over a period of time it is expected that this ratio is going to decrease to 1 in 4 individuals who are going to suffer from depression in one's lifestyle. It is also a burdensome disorder because the years lived with disability due to depression is very high. They were resulting in a lot of loss in terms of manpower, in terms of productivity that we see over the years. Comorbid conditions amount for largest portion of growing economic burden of depression. That is, individuals who are suffering from diabetes, individuals who are suffering from cardiovascular diseases, individuals with stroke who have depression are found to have more functional disability that is seen in these individuals. Some basic signs of depression, that is when a physician or when a clinician see a depressive patient, how can you differentiate depression from other disorders or just tiredness or weakness? So one of them, like depressed mood, loss of appetite, loss of interest, is something which is very characteristic, along with 4 or more of the other symptoms which are laid down by DSM-5, like sleep disturbances, psychomotor retardation, slowness in doing work, easy fatigability, there is cognitive dysfunction that is present, there is feelings of worthlessness, hopelessness, helplessness that may be present, and suicidal ideas. So a lot of, as everyone know right now, that decriminalization of suicide has been moved by MHCA Act 2017. Keeping in mind that individuals who actually commit suicide have a psychological background or a psychological disease that moves them to commit suicide, and depression being one of the most common reasons for individuals to commit suicide. This is a slide which shows a global burden of depression, just to tell that how big the disease is, how big the problem is. It is second leading cause of years lived with disability, with about 8.2% with major depressive disorder contributing to total global years lived with disability. It is also the leading cause of disability-adjusted life years, with 2.5% individuals globally suffering from major depressive disorders. Overall, it leads to 3.8% of the global disability-adjusted life years. In India, the picture is worse. That is, we have seen that people who are working right now in corporate world, people who come from a corporate background, especially with this background of COVID pandemic, are the worst hit. So around 42.5% individuals of corporate world suffer from depression. These are individuals who generally do not receive care because it is being expected, or it is it is understood that due to pressure of the work that they suffer from in corporate world, they tend to have certain sleep disturbances, eating irregularities, or lack of interaction with other individuals. So all these things are sometimes overlooked, thinking that they are going through such stressful moments, and underdiagnosed as just an adjustment disorder or just stress rather than depression. Besides India, it is also seen that all over the world, women are more affected by depression. Why women? Why we are talking about women today, or why depression particularly is directed towards women, or what causes women to be the victim of depression more? So it has been seen that there is a young age of onset in women, and 1 out of 2 mothers, that is women in postpartum period, are the ones which are commonly affected by depression. Overall, a women has multiple areas or multiple time in their whole lifetime where depression could be seen, as we know about premenstrual dysphoric disorders, premenstrual syndromes, then childbirth, then being pregnant itself. Pregnancy itself is one of the risk factors for women to develop depression. And post-menopausal or perimenopausal age are the women who are prone to develop depression. Depression also not only affects the women but also the children or the child when the mother is pregnant, in terms of care that she can provide for the child, and therefore has a direct effect on depression in the child over a period of years or in future. So almost 1 people, it has been seen, take their own, 1 million people take their own life each year, that is suicide, and the most common cause being depression in such individuals. The women are 2 to 3 times more prone to develop depression as compared to males. The reasons could be the social expectations out of women, hormonal imbalance that we see in women that happens all throughout their lifetime, and genetic susceptibility. Women are made that way that they are more susceptible to stress or depression. It is also seen that there is an early onset or a younger onset for girls as compared to boys. However, there is no particular age for depression, but women of the age 25 to 44 are more prone to develop depression, or there is higher age preponderance that is seen during this period of time. Women also have more episodes of depression. For example, if a male is having a single episode, a depressive episode in their lifetime, they may not have another episode. But women are more prone to develop depressive episode over a period of their lifetime. They tend to have multiple episodes and sometimes tend to develop a bipolar disorder also later because of the pregnancy-related depressive disorders that happen. Then lifetime risk of women was found to be around 20%, and it is seen that 20% of women suffer from depression during the whole lifetime. The 40% of women were found to have premenstrual syndrome, and 13 to 18% were found to have premenstrual dysphoric disorder. So just that menstrual cycle which women goes monthly make them more prone to develop depression. Then what are the causes of depression? We talked about what is depression, why women are more prone, but what could be the causes of depression? So there are multiple reasons why a person can develop depression besides stress that we commonly talk about. There are other biological factors such as genetic factors. There is a problem or this alteration of the HPA axis, that is hypothalamic pituitary adrenal axis. There is altered circadian rhythm. So a lot of one of the common feature of depression is decreased sleep. So that decreased sleep itself can precipitate a depressive episode. Then definitely there are psychosocial factors or psychological factors. That could be separation, that could be loss of near and dear ones. There could be a background of stress factors in the family. There could be IPR issues, interpersonal issues that are going between the family members. All this could act as a precipitating factor or a risk factor for a person to suffer from depression. Then there are definitely cultural factors. It has been seen that people who are more religious, more spiritually inclined, tend to have low depressive episodes. So religion, beliefs, attitudes towards illness, that is whether depression is actually considered an illness in their culture or not, is also very important, because as we have seen over the years, women are supposed to do certain things without saying anything or without complaining. So whenever a person or a woman complains, it is not taken seriously and we tend to overlook depression. So the pains or the somatic complaints, the tiredness, weakness is considered to be the part of a woman's life rather than taking it seriously and considering depression. So all these factors together may act as a risk factor for a woman to develop depression. Then there are other periods in a woman's life, like pregnancy that we talked about, infertility. Infertility itself acts as a very important factor for determining depression in a woman. First, the embarrassment related to infertility that women face, the couple trying hard to conceive and pressure coming from all the family members, the societal pressure that comes regarding infertility, and then failure to conceive, spending a lot of money for infertility issues and still not conceiving. All these factors together cause a lot of stress in a woman's life and can lead to depression in such situations. Besides this, during pregnancy, there could be difficulty in time management with right now a situation where women are at par with men in working. So handling your work along with pregnancy as well as household work itself can lead to time management issues, issues related to family, which can again make women prone to depression during pregnancy. Then post-pregnancy. If we talk about women who are post-pregnancy, everyone is familiar with maternity blues, but when these blues become long, that is more than 1 week, they return into postpartum depression. So maternity blues or postpartum depression could be common. Definitely, it is seen that around 80 to 90% of women suffer from maternity blues, but these blues do not require any treatment and they are not part of depression. But once it becomes more than a week, it may lead to mood lability, disturbed sleep, anxiety, irritability, carefulness. They sometimes develop severe depression, which goes into psychotic phase. But all of this, if present within 2 weeks and resolves on its own, does not require treatment. Treatment is required when it goes more than 2 weeks or it causes severe impairment in taking care of the child, in taking care of oneself. It has been seen that postpartum depression would be found in 10 to 20% of women who are in postpartum period. It could range from minor to severe. The minor symptoms being subsyndromal symptoms like pains, aches, disturbed sleep, decreased appetite, to changes in mood, to changes in cognition in form of decreased attention and concentration, death wishes, sometimes thoughts to harm the child, and to a severe extent that they may lead to infanticide or suicide in this individual. This is the time when we should be very serious in these postpartum females and give them proper treatment. They require inpatient treatment, and care of the child should also be taken into consideration when we see postpartum depression. For now, I told about women and the depression that is seen in women, so that when a physician or a clinician see these women during these period of times, during childbirth, during postpartum, or during childbearing period, during premenstrual period, we should not miss depression. Let it be a psychiatrist, a physician, a gynecologist, or any other person who is having contact with these women during these periods of time. Now I would like to come to the main topic, that is the comorbid depression that is seen in women. So there are many comorbidities which may be present with depression, and there are many diseases which have a comorbid depression. It has been seen that tuberculosis individuals, people who are suffering from tuberculosis, from HIV/AIDS, are the highest who suffer from depression. There are studies which say that around 80% of individuals who suffer from HIV have a comorbid depression. It is not only these severe diseases or life-threatening diseases that are associated with depression, but also common diseases, lifestyle diseases like hypertension, diabetes, diseases like epilepsy and stroke, which have been associated with depression. A rate of as high as 30% or 31% has been seen in epilepsy and stroke, whereas if we see general population, only 7 to 10% of individuals will develop depression. So as you can see, there is around 3 to 4-fold increase in depression that is seen with other comorbidities such as hypertension, diabetes, epilepsy, or stroke. So there are, I've listed down few diseases which may have comorbid depression, like myocardial infarctions, coronary artery diseases, congestive heart failures, asthma. Asthma being a long-term disease, a lifelong disease, is also associated with depression. COPDs, HIV, Parkinson's, encephalitis, epilepsies. Endocrinological diseases are one of the common diseases which are associated with depression, thyroid abnormalities, diabetes. Then we also have gastrointestinal diseases like GERD and irritable bowel syndrome, which have a two-way interaction with the depression if we see. Then anemia is one of the most common cause or most common finding that we see in depressed individuals because of the lack of appetite that they have, decreased self-care that they have. Then depression could also be drug-induced. So certain drugs which are associated with causing depression itself are also known. We'll talk about diabetes and depression. So diabetes and depression is a two-way lane. It has been seen that HPA axis hyperactivity, which is associated with increased cortisol levels, causes insulin resistance and thereby results in diabetes. Why this HPA axis hyperactivity occurs in depression is because of the stress. So there is a stress depression hypothesis which says that HPA axis hyperactivity is associated with increased cortisol levels, which we also see in depression, and thus the comorbid association of depression and type 2 diabetes. Studies were done and it was found that there was a very good relationship or very direct relationship between levels of HbA1c as well as the depressive symptoms that the individual has. That is, higher levels of HbA1c were associated with more depressive symptoms in an individual of diabetes mellitus. Also, increased prevalence was seen in depression of individuals who had complications of diabetes in terms of neurological complications, maybe ophthalmological complications, cardiac complications. So these individuals were found to have more depressive symptoms as compared to the normal populations. But it also, there were studies which showed that effective control of diabetes, that is, if we have a better control in terms of HbA1c levels, the sugar levels, the depressive symptoms were also found to be less in these individuals. The effective treatment of depression also helped in increased treatment adherence in these individuals. That is, the individuals were more open to taking treatment for diabetes. They had more positive outlook towards life and therefore wanted to have a proper treatment in terms of insulin requirements or anti-diabetic drugs. I think when a physician or when a clinician is seeing a patient with diabetes, we should always be looking at depressive symptoms. Another question which comes to our mind while treating such individual is, when a person having a depression comes to a clinician and asks about, and there is a dilemma regarding what medications to be continued, what not to be continued in terms of antidepressants that have been prescribed. So to lay that at rest, it has been seen that for depression and diabetes, CBT, that is cognitive behavioral therapy, is best. If there is no control or the depression is of more severity, then bupropion or SSRI, especially fluoxetine and sertraline, which were found to have direct decrease in HbA1c levels, should be tried. Escitalopram is also a good drug that can be given in such individuals. However, it was seen that TCAs, that is tricyclic antidepressants, and mirtazapine, which has been used to treat depression, have a negative effect on diabetic control. There was weight gain, there was orthostatic hypotension, there were also cardiac conduction defects which were seen in individuals with diabetes. So drugs such as TCAs and mirtazapine should be avoided with individuals who have depression and comorbid diabetes that is there. The other disease that we generally talk about is the cardiovascular diseases, especially the individuals who have smoking, who have obesity, individuals who have sedentary lifestyle were found to have both cardiovascular diseases as well as depression that is occurring together. So these are risk factors not only for the cardiovascular disease but also for depression. Also, as I told in previous slide, the HPA axis hyperactivation, which is responsible for developing cardiovascular diseases, has a background with stress-related changes that happen in depression. So depression, it was found to have 2 to 4-fold increase in cardiovascular diseases, 2 to 4-fold increase chance of mortality following cardiac disease, and it was also associated with sudden cardiac death. So individuals who have comorbid depression with heart diseases tend to have sudden cardiac deaths. Symptoms of depression also predict future coronary events. That is, individuals who have depressive symptoms for a long period of time were found to have some amount of stress-induced ischemia, which was associated with risk of developing cardiac events in the future. So the whole stress and cardiac the ischemia that is induced in the myocardium was associated with the cardiac events that happened in the future. So depression was found to have also effect on platelet aggregation. It increased the endothelial dysfunction that leads to impaired brachial flow. Also, it increased the level of endothelial 1. So all these factors were found to result in more cardiac diseases in women as well as men. But the cardiovascular disease was found to be the leading cause of death in women, and as a result, depression, when found, was there was a comorbid depression in such individuals. So for these individuals, if you have a cardiac patient, if the person has had a recent MI, what should be the drug of choice, or what should we be looking in terms of depression? So SSRIs were found to be the drug of choice. That is, serotonin reuptake inhibitors, selective serotonin reuptake inhibitors were found to be the drug of choice, with a special study which was done in sertraline. Sertraline was found to be the most efficacious in individuals with the cardiac disease that is present because of the antiplatelet and the cytochrome related interactions that are seen with the antidepressants. So SSRIs were found to have less of these interactions and were found to be the drug of choice. But other drugs such as mirtazapine and vortioxetine can also be considered when prescribing in individuals with cardiac diseases. However, it is again said, similarly as we see in diabetes, TCAs are the drugs which should be avoided in individuals with cardiac diseases. Next, we come to stroke. Post-stroke depression is one of the common things that has been noticed that neurologists come across. So it is the duty of a neurologist not to overlook depressive features in individuals who are recovering from stroke. It was seen that more than 80,000 women in 6-year follow-up studies had depression which was associated with a stroke risk. SSRIs was associated with increased stroke risk. That is because of the bleeding tendencies that we see with SSRIs. So SSRIs which were used in depression also act as a risk factor for women to develop stroke. Antidepressant use was associated with weight gain, with increased inflammation, abnormal bleedings, and hypertension, which all were risk factors for stroke. Fluoxetine specifically has been associated with increased bleeding time and therefore has is a more risk for the individual to develop stroke. The post-stroke depression is something which we need to talk about, something which needs to be treated. It has been seen that individuals who were being treated in acute care or in rehabilitation centers for post-stroke recovery, depression rates were as high as 19.3%. And in community setting, it could be around 14.1%. And it was the most frequently occurring psychiatric disorder after stroke, with other disorders like anxiety, there could be panic disorders, there could be psychosis that may be seen in these disorders. It is also seen that there is poor cognitive and functional outcome, which is seen in individuals with stroke survivors. The depression was associated with these poor outcomes. Because of the depression, individuals had difficulty recovering from stroke. The post-stroke depression goes underdiagnosed in as high as 80% of individuals. 50% of stroke survivors who develop major depression within the first 3 months have been found to have depression for the next 1 year. So you have a whole 1 year to diagnose this post-stroke depression which happens. The treatment is very easy. You have to tell about diet restrictions, you have to tell about sleep hygiene, exercise, occupational therapy, counseling, and cognitive behavioral therapy. Drugs, if required, fluoxetine, as I told, fluoxetine should be avoided because of the increased bleeding time. But however, it was seen that sertraline is a drug which can be used in such individuals. Citalopram is one of the drugs which can be used and which is found to be safe in these individuals. And treatment may be required for around 4 to 6 months post-stroke and they will be out of it. However, if untreated, it could be as high as 1 year and patients will still be having depressive symptoms post-stroke 1 year. Now we come to endocrinological disorders. There are multiple endocrinological disorders which are associated with depression, but I think our main focus is on thyroid dysfunction because we see that there are thyroid abnormalities that we pick up in individuals which we diagnose as depressed first, and then when we get a thyroid profile done, they are found to be having hypothyroidism. So depression is seen in 40% cases of hypothyroidism and 30% cases of hyperthyroidism. It was seen that 13.3% in women with premenstrual syndrome had hypothyroidism. So you can see there is a very close relationship between thyroid dysfunction as well as depression. So whenever we are treating a patient of thyroid abnormalities or depression, the other has to be checked. So if I'm treating a patient of depression, I keep a check on the thyroid function. And if a clinician is treating a patient of thyroid dysfunction, a check on depression is required. The most common thing that we come around is the overlap of these symptoms. As clinicians, we all know that hypothyroidism may present with loss of interest, there would be lethargy that may be seen, sleep may be more, appetite changes will be present, there may be decreased libido, there may be anorexia, there may be fatigue that may be seen, and all these symptoms overlap with depression. Suicidal ideations are something which are common to both, but at times overlooked in individuals who have hypothyroidism. So a close look at depressive symptoms in hypothyroidism patients is very important. The next question which comes to mind is what to treat. Shall I treat only depression or only hypothyroidism? So the answer is both need treatment. The treatment for depression may last from 4 to 6 months according to the individual's symptoms that are present, and the hypothyroidism, as and when corrected, these patient can be taken off the antidepressants, and a depressed individual when found to be having hypothyroidism, treatment for thyroid abnormality should also be started. Treatment for depression can be slowly tapered and stopped after 4 to 6 months depending upon the symptoms, but treatment for thyroid disorders need to be done continuously till the proper thyroid levels are attained and maintained. One of the common disorders, epilepsy. Epilepsy is also associated with depression. So the diagnosis of epilepsy itself is associated with a lot of stigma in our society. So that stigma can itself lead to depression. Besides that, there is a bidirectional relationship in terms of inflammatory markers, in terms of cytokine levels that we see in these individuals, in decreased activity of serotonin, norepinephrine, dopamine, and GABA that is seen in patients of epilepsy. So these are seen both in patients of epilepsy and depression. So in depression, when such levels are found, it is seen that there is worsening of seizure control. The seizure frequency is increased in these individuals, and severity of seizures are also increased in individuals who have comorbid depression. Depressed activity of these neurotransmitters, serotonin, norepinephrine, dopamine, and GABA, is also the basis of treatment of depression that we see. So when we treat depression, in a way we are trying to control epilepsy also, but that does not mean that antidepressants are the treatment choice for epileptic patients, but they should definitely be considered when we are seeing a patient of epilepsy, and we tend to at times overlook the depression that may be present in these individuals. So prevalence of depression and epilepsy could be as high as 60%, with women having more rates as compared to males, and patients with depression also have up to 6-fold higher risk of developing seizures as compared to normal individuals. So there's a small flowchart showing how the epilepsy, depression, and sometimes autism spectrum disorders have similar basis in terms of neurotransmitters, H-wave dysregulation that happens. So what could be the symptoms in epilepsy? As clinicians, you would have seen different manifestations of epilepsy, temporal lobe epilepsy presenting as behavioral disorders. They could be post-epileptic changes. They could be interictal changes that happen. So it could result in a mood disorder, which may manifest as anxiety disorder, depression. It could be also interictal dysphoric disorder. It could be bipolar disorder. Or it could be a dysthymia, that is a long-term depressive symptoms that are seen in these epileptic individuals. So my request to neurologists or to clinicians who see epileptic patients not to miss depression in these individuals, and screening is very important. Just asking a simple question of how are they feeling, or is there any sadness, what they think about their diagnosis is very important. In epilepsy also, SSRIs like citalopram are the drug of choice, but we need to avoid drugs such as bupropion, clomipramine, amoxicillin, and CBD can help in these individuals. Then we can see that depression is found to have a close relation with cancer treatment also. So cancer being a life-changing diagnosis itself is associated with depression. But individuals with cancer treatment who have depressive symptoms, it was found that they have poor outcomes or poor response rate as individuals who do not have depressive symptoms. So higher rate of depression was reported in these individuals as high as 1.5 to 50%, depending upon the type of cancer that they were suffering. Major depression was associated with a high risk for breast cancer. As you can see in this diagram, again the HPA axis, which is associated with release of corticosteroids from the adrenal glands, is responsible for these tumor genesis that occurs and resulting in cancer. There is also a chronic stress hypothesis, which is associated with hypercortisolemia, which is responsible and which forms the basis of both depression as well as the carcinogenesis which takes place. Then in these cancer patients, it was seen that if we treat depression, the outcomes are better with the treatment for cancer. The other disorders, especially during this COVID time, the chronic respiratory diseases, the individuals who are suffering from COPDs but actually do not have any COVID symptoms. So just the fear that maybe our symptom or the COPD manifestation could be a COVID manifestation itself can result in depression in these individuals. So the most important risk factor for COPD is smoking, and smoking itself is found to be a major risk factor for depression. So there is a bidirectional interaction between the individuals who have smoking as a risk factor for both depression and chronic respiratory diseases. And from there, as you see, it is a downward spiral. It goes to a poor quality of life, to weight loss, to isolation, depression, severe dyspnea, and finally resulting in mortality. So individuals who have comorbid depression with COPD needs to be treated so that there is a better outcome, there is more interaction between these individuals and others. They do not go into isolation and thus depression. So in female COPD patients, depression was associated with increase of significant mortality rates, which was more than the risk conferred by coronary heart disease, heart failure, or lung cancer. So if you see these statistics, you will feel that individuals who have COPD, females who have COPD with depression, have higher mortality even when you compare with cardiac diseases. And depression also increased COPD exacerbations, extended the length of stay in hospital, and affected the quality of life of these individuals. Now to less common disorders, if I may say, multiple sclerosis is one disorder which physicians come across very commonly. It is also seen that psychiatric disorders, because of the psychological impact of having a diagnosis of multiple sclerosis, the prognosis of multiple sclerosis, the perceived lack of support from the family members, or unhelpful coping styles, or increased stress due to multiple sclerosis, all of these are a risk factor for developing depression. The point prevalence of depression was found to be as high as around 27% in individuals with multiple sclerosis, with a lifetime prevalence of around 50%, and suicide rates were found to be 2 to 7 times higher when compared to general population in population of multiple sclerosis suffering from depression. One of the dilemma that we all face, if a person has renal impairment, person has hepatic impairment, what we shall be doing? So the dictum remains the same as it is for all other medical conditions. We have to start low and go slow, even with the antidepressants. Prescribe as few drugs as possible. Drugs like citalopram and sertraline are the choice of drugs in renal impairment. Drugs like imipramine, paroxetine, citalopram are preferred in hepatic impairment. It is seen that depression is very common in patients with end-stage renal diseases and therefore need to be treated during those end-stage renal diseases. But the dictum remains the same, that to start low and go slow. Depression and HIV is something which as clinicians you see on daily basis. The prevalence is as high as 80 to 84%, and it itself act as a risk factor. A person with depression tends to have high risk behavior. They could be searching for a high that they want to get out of this low of depression. Smoking, injectable drug use, high sexual behaviors, all these could act as risk factors for HIV, which is seen in severely depressed individuals because they are searching or they are looking for that high. The first line of drugs again are the SSRIs. However, there is an interaction between the drugs of HIV treatment and SSRIs. So we should keep in mind the risk of serotonin syndrome, which may develop in these individuals who are on treatment for both HIV as well as depression. So it's one of the few last slides that I have to discuss. What is a treatment for depression? Treatment for depression remains the same whether the individual is suffering from a comorbid medical disorder or not. Only thing is we have to be very sure about what kind of drug we are prescribing. So there are multiple classes of drugs that are available: SSRIs, SNRIs, then there are TCAs, then there are newer drugs that are available. We have ketamine as a drug right now, new drug for treatment. But depending upon the disease, as I told earlier, in diabetes, in patients with cardiac diseases, SSRIs being a good drug of choice. In stroke patients, to avoid SSRIs because of the increased bleeding potential that may be seen. So all these things should be kept in mind. Besides the drugs, besides the psychotropics that we use, we definitely need to have a good social support for these individuals. Not only because of the depression that they've developed, but also because of the diagnosis of the medical disorder that they have. For example, individuals with epilepsy, individuals with HIV, individuals with multiple sclerosis. So social support or social family support plays a very important role in these individuals. There is also therapy that is available, cognitive behavioral therapy, supportive therapy, then there could be individual psychotherapy that we use, and lifestyle changes which are beneficial not only for depression, but also for other medical disorders like for diabetes, control of diet, exercise, meditation, yoga. All these things are going to help in coming out of depression besides using psychotropics and social support. Extreme cases which have high suicidal intents, cases which have severe depression, cases in which there is a severe impairment of their day-to-day functioning, ECT or electroconvulsive therapy is one of the treatment of choice. So this is the last slide of my presentation. So by the end of this, I really want to bring it across that there is a gender bias when we see depression. Women are more prone to develop depression. Uncontrolled depression is associated with comorbidities like diabetes, thyroid disorders, hypertension, cardiovascular diseases, stroke, pulmonary disorders like COPD, and even cancers. As we told, breast cancer is found to be at a high rate in individuals who are depressed. The basic pathology that we see is due to HPA axis overstimulation or due to inflammation in other disorders like cancer that we see. So a requirement of an all-round integrated approach is required, not only to treat depression, but also these medical disorders, not only by the psychiatrists, but also by other clinicians who are the first contact with individuals with medical disorders and thus help in identifying these depression and properly referring these individuals to the psychiatrist as and when required, depending upon the severity of these symptoms of depression. With this, I come to the end of my presentation. Thank you for listening so patiently. I would be ready to take any questions if we have in the audience.
There are a few questions. There are about 2-3 questions which has come. One is that can normal sadness of bereavement proceed to depression? Any indications to be prescribed in that case?
Okay, so now normal sadness or bereavement when we talk about grief reaction. A normal grief reaction is considered to be there within the first 3 to 6 months of anyone's death. That is considered to be normal. But if it is to the extent that the person has suicidal ideas, the person has a poor self-care, person has affected day-to-day activities, or if this normal sadness is prolonged for a period of 1 year, we consider it to be depression and it needs to be treated. The medicines would definitely depend upon the individual, the comorbid conditions that he is suffering from, but generally SSRIs are the drugs that we prescribe, but definitely a medical background, the person's medical history, any previous history of similar episodes, all these play an important role in deciding what drug needs to be used for such individuals. But I think I've answered sadness and bereavement definitely can lead to depression, and if symptoms prolong, if symptoms are severe, psychiatric care should be sought by such an individual.
Thanks a lot. There's one more question very close to this one only. Like, how can we differentiate the normal sadness and lack of pleasure seen in bereavement from the depression? This is another question.
Yes. So as I told earlier, also it depends upon the extent of the symptoms. For example, if it is not allowing you to get out of the bed, or if it is not allowing you to do your day-to-day activities, or if you have suicidal ideas, so these are the symptoms, or these are the indicators that it is no longer a normal bereavement. It needs treatment, and it has gone to the category of depression. One, and second, if it is prolonged, if it does not resolve within 3 to 6 months of the loss, it is considered to be depression and needs to be treated as depression.
That's all the questions we have. Now over to Dr. Srihari sir.
I really want Dr. Srihari to share his experiences as a clinician, how frequently he sees such depressive individuals in patients of cardiac disorders, diabetes. Sir, your mic is muted, I think.
Muted, sir. Sir, still it's not audible, sir. You have to just click that camera button, video button, sir. Once you click that, it will start. Sir, yes, you can still speak, sir. Sir, is there? Hello?
Hello? Hello?
I think sir again had that some
Ma'am, can you just tell sir to reload the page? There must be a network issue.
Yeah.
Yeah, please. Thank you.
just try to reload the page, I think it will come, sir, no?
Yeah, because you have given an unmute also. So, Dr. Srihari, if you can do an F5 or maybe reload your page, then it will come. So, I'd request somebody from Alchem to talk to Dr. Srihari so that Nagappa or Mr. Obi Reddy, so that we help him. So in the meantime, Dr. Khushbu, there are a couple of questions if you would like to take it by the time.
She has addressed that about Farasji.
Okay, already addressed it.
She has addressed that.
So we just wait for Dr. Srihari. Just for a minute.
Sir is trying to actually re-log in it. I think within a minute I can re-log in.
Yes, in sir has come.
Yes, yes. Yeah. Over to you, sir.
Over to you, sir.
In a physician practice, we see multiple somatic symptoms. One thing, and cardiac neurosis is a common thing what we see. The people coming to OPDs repeatedly taking ECGs and bothering us. Okay? Such people has to be treated or not?
Yes, sir. If we see for somatic symptoms, individuals who have this health-seeking behavior or sickness behavior, we call it, sir. So once they go to a doctor, they have this tendency to again go to the doctor, get this reassurance from the doctor. So these individuals require psychiatric treatment. That treatment could be through the counseling or therapy itself, may not be medications, but definitely some amount of intervention is required from the psychiatrist side because, as you said, cardiac neurosis. We also see a lot of individuals just due to heartburn, they'll come, no, there is a problem with the heart, I need this ECG to be taken and repeated ECGs will be done. So these fall in this spectrum where they have developed this sickness behavior, this attention-seeking behavior, if we may say so, and they definitely need treatment.
Okay. In adults and young individuals, obesity is one more cause for
Yes, sir. Yes, and besides depression, that obesity is also a risk factor for other cardiovascular diseases which they may develop at such a young age. And I think with this lockdown and with this COVID thing, people being at home, not moving, online classes, webinars that are going on, it is just going to increase.
Yes. Anyway, very good session.
Thank you, sir.
Thanks to Dr. Khushbu Devani for her excellent and informative presentation. Thank you for your valuable time.
Thank you, sir. Thank you for taking out time, sir, for this session.
In fact, thank you so much, Dr. Srihari. Thank you so much, Dr. Khushbu. In fact, at the outset, I take this opportunity to thank you for sharing your expertise on this very important topic. This information which you shared was very useful, will be very useful, and it is very practical. And I'm sure many of the doctors who are watching it would have been benefited from the experience of our faculties. I would like to thank you, Dr. Srihari, as well as Dr. Khushbu, for bringing all the relevant points into the discussion, for making the session very useful for all the doctors. At the same time, I would also like to thank all the doctors who have joined for this webinar and making this program a very highly successful one. Healthcare for all is the commitment at Alchem. We solicit your continuous prescription support for our key brands such as Nusita Plus, Nusita Light, Nusita Mini, Nusita, Nelzap MD and Nelzap Flip. Our brands are available at most at all the chemists, but in case if there are any difficulties, you may always reach us in fact through our colleagues. Thank you so much, and please take care of your health while serving the patient and nation. Thank you. Thank you so much, one and all.
Thank you. Thank you.
Thank you.